So we're ready to kick off with our second panel. The second panel is entitled Solutions for Next Generation Nurses, Education, Technology, and Policy. Once again, we've got Tracey Wilen-Daugenti, who's going to be moderating the panel. And I'd also like to introduce our other esteemed panelists. We have Dawn Bazargo. Dawn is the Senior Vice President for the Center of Nursing Advancement, United Health Group. And next to Dawn, we have Carlton Brown. Carlton is the president of the Oncology Nursing Society, and he's an assistant professor at the University of Delaware, College of Health Sciences, School of Nursing. And he's also the past president of Oncology Nursing, the Oncology Nursing Certification Corporation. We also have Parvati Dev, who is the CEO of Innovation in Learning Incorporated. She's a distinguished visiting scholar at Stanford University and former director of Summit Lab, Stanford University School of Medicine. And finally, we have Pamela Fuller. Pamela is the dean of the University of Phoenix's College of Nursing, and she's a board member of the Southwest Arizona Board of the American Liver Foundation and a member of Arizona State's Board of Nursing Education Committee. So with that, we'll turn it over to Tracey. Once again, a reminder, you have the opportunity to submit questions via the cards, just as we did for the last panel. So thank you, and Tracey.
Thank you, Chris. And the title of this panel is Solutions for Next Generation Nurses, Education, Technology, and Policy. So let's start off with education. In a recent study that came out of my institute, we found actually that learners who learn when they earn have a greater return on investment for their tuition dollars, around 26%, than those right out of high school, which is at 14%. Both positive, but I think somewhat indicative of the future of education, working, and learning. Pam, you're the dean of the College of Nursing, University of Phoenix, the nation's largest school with over 13,000 students, 50 states, foreign countries. 60% or so of your students are these working learners, people who learn and earn. Can you tell us more about your students?
Yes. Well, we do have a very diverse group of students. The majority, if not almost all of them, of course, are not unlike everyone in this room who have, full-time jobs, families, children, and are working to increase their educational level, whether they're new nurses going into a pre-licensure program or whether they're nurses moving on into their baccalaureate or their master's program. So the demographics used to be that nursing students were 18 to 24 in traditional schools and had parents that would help them. That's not the case in today's environment, and our school is not like is like all other schools. The majority of schools today see the non-traditional student as the traditional student. And so we have really captured at the University of Phoenix the ability to have those students gain access to education and to the levels of education that we offer through both a ground or local presence as well as an online presence.
So, Dawn, United Health Group, leading healthcare company serving more than 75 million people worldwide, one of the nation's largest employers of nurses. You're Senior Vice President of the Center of Nursing Advancement, and you have managed the professional development of more than 7,000 nurses. How can healthcare organizations and educators work together to ensure that nursing graduates have the right skills?
I think there's tremendous opportunity for healthcare organizations, delivery system organizations to work directly with academia. And it happens in a variety of ways. We found through the Center for Nursing Advancement at United Health Group that our nurses had an opportunity to really grow personally and professionally, and as well as give a contribution back to nursing education. So some things that we're doing is partnering with academia to consult on nursing education, but also we're actually offering up our nurse leaders to serve in adjunct faculty roles. We have approximately 50 of our nurses serving in a variety of roles with distinguished institutions across the country to serve as mentors, preceptors, but really offer their keen practice insights into nursing education today. One of the things that we've seen as a large employer of nurses is that the skills and capabilities and mindset of nurses of today that are being produced today need to evolve over time. And by keeping one foot in clinical practice in the delivery system or in our organization, and even one foot in academia, we contribute to the nursing shortage because we're providing needed capacity. We're getting in front of new nurses and exposing them to a variety of different leaders. But also it's giving us a sense of understanding what the needs and requirements are of nurses of today as we think about them as potential employees.
Okay, thank you. So Carl, Pam had noted to me earlier, she's got over 850 faculty. And you serve as president of the Oncology Nursing Society, a 37,000 member organization dedicated to improving cancer care. But you're also an assistant professor at the University of Delaware. And we actually talked about a faculty shortage. What role can you play in alleviating the faculty shortage?
Well, first of all, we should probably talk quite a bit about the faculty shortage. I think in the earlier panel, Maureen really highlighted something that we're seeing, which is her son wants to go to nursing school, but he's waiting for 2 years to go to nursing school. And I think in part that is in relationship to the actual faculty shortage. I know that there is a state where they have decreased, a state nursing school who in their incoming freshman class will decrease their BSN students by 25% because of budget issues. So, you know, while we're supposed to be producing more nurses for the future, in some realities, because of the faculty shortage, we're not going to be able to make those numbers. And it really is quite a bit of a problem. I'll share with you that a faculty member, and so why is that? Why can't we draw nurses to faculty? The issue is that a faculty member who has somebody that graduated as one of their students in May, that student will go to work in maybe an emergency room or a critical care and work weekends and night shift and probably make more money than the faculty member who's teaching them. Now, being a faculty member isn't all about money, but that's really, I think, what's driving nurses not coming to faculty. Until we solve that problem, we're not going to be able to produce more nurses. So what are we doing? Certainly at the School of Nursing, trying to retain the faculty that we have, because they live in a world where their counterparts are making more money in different areas, and it's not uncommon for them to leave, which creates the problem. So one of the areas that we're doing, certainly at the School of Nursing, is trying to retain what we have while also trying to draw more.
So Pam, you're nodding. It sounds like, it looks like you have a comment. Would you like to comment on that?
Well, totally agree with what you're saying there, and it's difficult to retain good teaching faculty whenever there is an economic need for them to make money to support their families and so forth. At the University of Phoenix, we have an opportunity to use most of our faculty, or what we call practitioner faculty, and so they really come to us because they just love to teach. They have full-time jobs sometimes, or part-time jobs in areas that they love. They bring expertise to the classroom, which is very good, but they love to teach, and so that's why they come and teach with us, because it's important. But they supplement their income often, and they, in fact, a couple of people in the room have came up to me today and said that they are faculty with us through our online program. So I think it's the blend of the type of faculty that we embrace and we honor at the University of Phoenix that helps us, keep a good cadre of faculty for our students in the classroom, whether it's online or on the ground. But the faculty shortage is a monumental issue if we're trying to really move that associate to baccalaureate needle, as well as produce new nurses. It's a problem.
Parvati, you're the leader in technology and healthcare education, the CEO of Innovation in Learning, a company that designs and implements leading-edge learning technologies for the healthcare market, and you were formerly at Summit Research Lab at Stanford. Is technology in education a solution to educate faculty, nurses, physicians? Tell us more about that.
It's certainly a very good tool. I can never say it's the full solution. But for example, remote learning has been very successfully using technology, web, video, e-learning. And I would say I love to use Christensen's curve of disruption. And on the curve of disruption, it's well up there as a disruptive technology that's changing how people are learning, how nurses are learning. And simulation is the up-and-coming new tool. And what simulation does, which is really different, is it puts you in the experience. You get to feel, not just learn abstractly. And I think that is a huge step to bringing nurses into the practice before you actually put them in practice. And I think that the newest technology, which is what we espouse, virtual environments, converges these two. It brings together remote learners into virtual simulation environments, giving them the experiential learning, but from their home or work environments.
Well, actually, let's dive a little deeper into the technologies, because we've talked now about simulations, electronic health records, but you're really moving out there now into virtual worlds. And I'm sure a lot of people in the room would love to hear more about, make sure I say it, the CliniSpace and DynaPatient. Could you talk a little bit about that?
Sure. It's so nice of you to allow me to talk about that. Well, but CliniSpace is a virtual environment. It's a virtual hospital, it's a virtual clinic, and these are spaces where people log in as role players, nurses, physicians, pharmacists, RTs, and they have virtual patients in them. These are the DynaPatients. And the reason they're called DynaPatients is because they've got a physiology that dynamically changes. So they're getting worse, and if you do the right things and all the equipment is working in that virtual space, then you could actually look after the patient. But I think the most important part of virtual environments is the ability to speak with each other. That's what makes it real. That's what makes it immersive. When two people meet in a virtual space, if Pam can say, "Hi, Carl, glad that you're on the shift today," it's like they're both in that same ward. And it's amazing. It's a wonderful green technology, of course.
So let me just review on the DynaPatient. So I could come in as a cancer person with cancer, and I will start to deteriorate, it sounds like, in the virtual world unless someone takes action. So does that elicit an emotion or a response?
Yes, yes. My favorite one is where the trauma patient's blood pressure is dropping because they're bleeding, and the person who's taking care of the patient saying, "My blood pressure is going up," and that one goes down. And of course, you can do the right things and take care of the patient.
So Pam, you use a lot of technologies at the University of Phoenix. Could you give us the wide spectrum of the types of technologies and how you use it? Because you have on-site, you have hybrid, you have online. Are you venturing into the virtual world?
We need to talk.
I think you're using some of Christy's technologies,
Yes,
so tell us more about that.
We do have simulation labs in 4 of our campus locations, and where Christy was talking about the high fidelity simulations and the reality of what it feels like when you walk into the simulated environment, and all of a sudden within 30 seconds to a minute the student goes, "Oh my gosh, I'm totally responsible for this patient. I have to make the clinical judgments and decisions," and it all starts to unfold. And so the mannequins are a great opportunity, but it's the methodology of teaching that makes it different. And our faculty have developed case scenarios that match to our curriculum, that match to our clinical sites, where we look at and we have them practice on these simulation and these patient scenario environments. And then, of course, the students debrief with one another as well as the faculty. And this gives them an opportunity to really look at themselves and reflect on what they said, what they didn't say, et cetera. So that is just one piece of technology. But we also have in our master's program and our baccalaureate completion program virtual technologies that are very important. the textbooks and the vendors in which we use over the last 5 years have really become robust in giving us, or building resources in terms of virtual classrooms. So as she was saying, we have a virtual hospital. We can have multidisciplinary teams talk to one another or role play that technology in the classroom, which brings to life a real situation. As was mentioned in the last panel, one of the needs to improve is that communication between nurse and physician and pharmacist. And the cues and competencies in the IOM report talk about how the communication is not there. And so the virtual organizations and the virtual ability to learn gives us an opportunity to actually practice that before we go out into the physical environment.
Carl, we chatted a little bit about skills. When Pam and I talked, she said she learned to give a shot in an orange. And now we've learned about simulations, virtual worlds. At Delaware, you said you use actors and actresses. What about the skills? Is the nursing student ready for the future? Do they have the right skills to bring the whole practice forward?
Well, I think simulation brings that to them and prepares them. So at the University of Delaware, in their junior year, their entire junior year is simulation. So they can be exposed to any type of patients. For instance, if I take a group of nursing students into a med-surg unit, we may never see a patient with appendicitis. So one of the most common medical surgical disorders, so that student may never see a patient with appendicitis without using simulation. But we can expose them to that through simulation so that they will see those common illnesses that they're going to see. Another thing I was thinking about was I was a nurse manager of a stem cell transplant unit, and I had a nurse that was her time for the first patient that she ever cared for that died. That expired. And through simulation, we could walk that patient through that experience of a patient dying. I mean, you can make the mannequin die, you can make them cry, you can make them stop breathing. And that, while it's not completely the same, it does expose them to the reality of that. So you can teach them some really great skills because, as I said, they may never see those skills in their nursing school, and then the first day they show up in a clinical setting and they have somebody that's dying, per se. And believe it or not, I think that in simulation, when that mannequin dies, you do see the students are so into it that some of them will cry, that they will relate to it. So that's just two examples.
Okay. Let's talk a little bit about innovative solutions. Dawn, the Center for Nursing Advancement has developed some innovative programs to increase nurse retention by improving the nurse's workplace well-being. Can you describe some of these programs and the impact?
I'd be happy to. The Center for Nursing Advancement was established about 3 years ago as a mechanism of really changing the culture in our organization to better recognize the contributions that our nurses make to our business and to improving the health and well-being of those that we serve. We also observe, though, that nursing by nature is a high turnover profession, and so we took on a number of strategies to address the drivers of retention and turnover, to include creating a strong culture of engagement. I'm really proud to say over the first couple years of the center's existence, we increased our nurse engagement scores by 6%. And that now paces higher than our non-nurse workforce. So we had a larger gap to close. We've now exceeded that and are sustaining those dramatic improvements. The other thing we've done is looked at any structural procedural issues that really get in the way of nurses being successful in our organization. And I know it's not unique to our company. And it's things about hiring and retaining and professional development, leadership development of our nurses. A couple other programs I would comment on have to do with nurse mentoring. We launched a program a year ago called Inspire that paired internal nurse mentees with mentors to really address that transition gap when we hire nurses from a different type of organization, bring them into a business environment, and support their development and onboarding. And we're seeing very, very positive benefits from that program as well. The last program I'll mention is around leadership development. I've had the opportunity to partner with the University University of St. Thomas in the Twin Cities to build out a leadership and executive mindset development program, because we realized there were gaps in the movement of nurses to move into the C-suite or executive level roles. They were trained to perform tasks very effectively, but when it came to things like executive communications, systems thinking, change management, we were encountering some deficiencies. So we're now putting nurse leaders through sort of a boot camp type cohort program and just seeing remarkable results in terms of preparing nurses to serve in broader leadership roles.
Nurses as executives.
That's correct.
Excellent. Carl, the Oncology Nursing Society is very active in shaping healthcare policy, encouraging nurses to become advocates for healthcare issues. How important is it for nurses to be able to communicate with policymakers, and what's your advice for them to do this?
It's immensely important, in spending quite a bit of time on the Hill and meeting with representatives and, and the senators. They want to hear from nurses about nursing issues. And I think some of the best ways to communicate with them is to share a personal story from a patient that you're caring for. It's important, and some of the things that we do are we have a program called NIWI, Nurses in Washington Institute, where we bring nurses in to learn how to talk with their representatives. One of the things I find so interesting, we were working with a group of our members who were researchers, very astute nurses, been nurses for 25, 30 years, PhD, great research experience. But when we talked with them, they didn't feel comfortable. Here are these astute leaders that didn't feel comfortable with going in and sitting down and talking with their representatives. So trying to, educate them to make them feel comfortable. So recommendations would be to get involved with them before you need something. So, go and visit them in their meetings, because when you need something, say, for instance, for nursing, probably so does every other nurse, and you're all competing for that one voice. So that would be one recommendation. Make a visit when you come here to Washington, or visit them at home. So go and visit them at home. So that would be two recommendations. The other thing is not to, they're just average people as well, and they want to hear stories of their constituents. So I think people find them to be overwhelming, but that's once you sit down and talk with them or their staff, you learn that they're just normal people as well.
It may be a part of not knowing how to engage, as well as not being part of it, you're not living here or part of the community. Pam, we talked a little bit about the Institute of Medicine's recommendations, and how has your organization responded to this call for action and innovation?
The Institution of Medicine report, it was actually done by a cohort of different healthcare leaders. So it's not a nursing report. Physicians, dentists, pharmacists, nursing were all part of this. And as part of the recommendation is to look at where should the future of our healthcare of our nation go? Where should it be? And how are we going to respond to that need? And from that outcropped what nurses should do and how nurses should play a role in this whole healthcare environment in our nation. And so we are looking at their recommendation, and there are several that I'm sure many of you in the room have read those recommendations. And then we are looking at our curriculum in terms of how can we incorporate those recommendations into our curriculum, and how can we educate our nurses. One of the recommendations is that nurses should practice at their highest level of degree. And in our family nurse practitioner program, in some of the states, our graduates can practice without being under a physician's license, and in other states they have to be under a physician license. So then it goes back to political awareness of talking to our legislators, state legislators, and showing that in order to move the health of our nation, just in that one area alone, that nurse practitioners need to be able to practice at their highest level and make those critical decisions and make the decisions they've been trained to make. So we talk to our students, our advanced practice students, about those issues. We then take a look at the rest of those, which is called cues and competencies, and those competencies are being looked at in every single course, and are we meeting those? And there are definitely some gaps, and that's the cues and competencies are the KSAs, which is knowledge, skills, and attitudes. We've done a pretty good job as nursing schools about skills. We can train our nurses fairly well on our skills. And then our attitudes, which is what we talked about earlier about caring, about where do we put into our curriculum the art of nursing and the caring of nursing, and how should we present that in our curriculum and to our students. And so the knowledge and the skill. So we are actually in our program right now dissecting every single course and looking at how we can move the recommendations and the competencies and be able to evaluate where we put those competencies and show that we have outcomes.
Thank you. Parvati, you've developed e-learning for a variety of learners in the medical field, but you yourself are an engineer through PhD of engineering. And my sense is engineering is predictable, it's facts, it's figures. And then you get into the medical environment and you have human and you have unknowns. Is learning the same, or what adjustments have you observed that you've had to make with technologies and distributing to nurses and doctors?
Well, at the core, engineering is indeed based on numbers, mathematics. If there isn't a single right answer, there's a range of right answers. And medicine at the core, there is a fair amount of knowledge about how the human body works. There's a huge amount we don't know. So a lot of training in medicine for nurses, for physicians, is as much experience-based as it is fact-based. And I think senior engineers do have to learn, get more experiences in the real world, but the whole medical area, there's a huge amount of transfer of knowledge through experience. Mm-hmm. And that's why I do feel very much that the simulation approach is key to learning before you are with the patient and learning on the patient and perhaps making errors you shouldn't make.
So Pam had mentioned that she was implementing not only the Institute of Medicine, but also the safety recommendations into the curriculum. Can technology enhance safety in e-learning or medical situations in your experience with your new products?
Yeah, actually, we have been collaborating with one of the big safety groups. They call the Institute for Healthcare Improvement out of Cambridge, Massachusetts, IHI. And IHI is a leader in improving quality and safety and performance in hospitals. And we've done a pilot with them. It's just a pilot still, taking a virtual hospital and setting up situations which the faculty can vary. They can do it the way they want. But setting up situations where things are wrong. So we began with a ventilated patient. It's the sort of the classic categorical situation where safety can be compromised because of the tube that's going down into your throat. And when the person learning walks in, they've got to do things like, is the bed angle correct? Is the head raised? Is the oral care being done every day and in the right way? Are they giving the right peptic ulcer medication? So there's a sequence of things they have to do. And it's a combination of looking at the patient, looking at the room, looking at the chart, seeing what the physician ordered, seeing what the nurse executed and noted, and talking. Mm-hmm. And we teach, and they use that simulation to go through that exercise. And that's just one of so many safety issues that you can teach through this sort of simulation exercise. I think the exciting thing is it's okay to learn one situation. I think you could learn it very well. But now you have 30 safety situations. You really, and they're coming at you, and you don't know what's right, what has been executed correctly, and what's not been. And so there, a simulated ward, a simulated hospital,
Right.
Got lots of potential.
You know, I just met a surgeon who uses augmented virtual reality as part of surgery, and I asked him, did it help with safety? And he said, you know, Tracey, it's the difference between exact and precise. And when you're dealing with a human life, you want precise. And so his feeling was that technology was a part and parcel of moving forward safety in healthcare.
Could I just comment on that?
Yes.
For example, the people who train on laparoscopic surgery simulators, it has been shown through studies that if you go through that before you enter the OR and use the tools, you have you work faster, you have less errors in your movements, because complex movement, you hit tissue less often, so less injury. There's just no question that beginning with the simulator is better for the patient.
Okay. Well, Carl, you mentioned that people are living longer. And so because we're living longer, we're going to experience every genetic item that might be on our radar. And I think you mentioned that because people said, are more people getting cancer? And you said, well, no, they're living longer, and if you're supposed to get cancer. Can you just talk a little bit about that and how age and oncology and some of the areas that you're seeing?
Well, primarily, we think of cancer as being an elderly disease process. Of course, we see children or young adults who have cancer, but a majority of the cancers that you have in the United States and around the world are in your elderly population. So let's back up a little bit now that because of medications like Lipitor, cardiac medications, things that are making people live past those potential cardiac events, they're living old enough so that they actually produce cancers that maybe they were genetically supposed to produce. And so we certainly are seeing more and more patients. I don't think, as I was sharing with you, I don't think that we're seeing more cancer, or these people are living longer so that they can produce those cancers. And that becomes a concern that in the year 2020, we're going to have an increase of people 65 years and older by 81%. And that means those patients then are going to more potentially produce with cancers. That means we need to have more and more oncology healthcare providers, nurses, doctors, PAs to actually care for those patients.
And then you had also mentioned that because of less time in the hospital, but patients are more sick, we have more outpatient. Are you seeing that in oncology and other areas, and how do you address that?
Well, 10 years ago, lots of patients that were being treated with cancer were being treated inpatient, and over the last 5 years or so, we've seen those patients move more outpatient. So they go in every 3 weeks for chemotherapy for breast cancer, for example. Now I think what we're seeing is a push even from the outpatient center into the homes, where patients are being treated, administered chemotherapy at home. And so that really changes the way nurses have to think. It certainly was a change from inpatient when everything you needed was right there to outpatient and then to home. And what that really creates from somebody who's interested in symptoms, if somebody comes in and they get chemotherapy today and we don't see them for 3 more weeks for their next cycle of chemotherapy, we have no idea what symptoms they are experiencing. So some new systems to kind of track symptoms on patients on a daily basis by telephone, by technology, so that one patient that is having a rating of 10 of nausea, we want to know about that so that we can help that patient. So there are certainly technologies to that, but I say that if you are in the hospital these days, you are really very sick. And I'm sure that Maureen and others can really speak to that. If you are in the hospital today, people have their gallbladder out and they go home in 18 hours, or they have a cesarean section and go home in 24 hours. And think of how different that is than even 2 or 3 years ago for care.
Well, let me touch on that with Dawn. You've mentioned that nursing can be one of the most stressful professions, and what can be done to encourage nurses to practice self-care, be inspired to stay in nursing despite the stress?
It's a great question. We all know nursing is a highly stressful profession. It's also extremely rewarding. We often care for others at the expense of ourselves, and that takes a toll on each of us. And we also know that stress is extremely costly to society and to companies. There's some evidence that about 70% of primary care visits have a stress-related etiology. And there was a recent study that indicated that about $300 billion are spent by companies in the US tied to presenteeism, lost time, disability, and workers' comp claims. So we realized that early on and recognized for us to really support our nursing workforce at United Health Group, we wanted to also provide them with tools and resources that they could use to manage compassion fatigue, as was mentioned on the previous panel, and just their workplace and non-workplace stress. It also happened to be my doctoral thesis. And as a psychiatric nurse, I was always intrigued with the mind-body and the relationship between that and health and performance. So we had the opportunity to test an evidence-based intervention called mindfulness-based stress reduction with about 40 nurses in our organization last year. And because about 64% of our nurses work at home, we had to modify the typical delivery format, which is classroom-based. So we innovated the traditional program and brought our nurses together the first and the last session, and then delivered the intervention telephonically for the middle 6 sessions. So I never thought this would work. We brought our nurses together on the phone in the evening. We rolled out our yoga mats, and we practiced meditation together. We practiced yoga. We had some nurses grab their spouses who did yoga together with them, and ran the program that way. And it was remarkable in terms of the results that we observed with the nurses that received the intervention. They reported statistically significant reductions in perceived stress, lower personal and professional burnout, lots of changes on the SF-12 scale, and positive changes in terms of self-compassion. You can't take care of others if you don't take care of yourself very well. Serenity and empathy, all indicators that translate to good patient care. So we were really proud about the impact that we observed with this intervention within our own nursing population. I think it has a direct tie to retention, keeping nurses in nursing, as well as keeping nursing a profession that really is delight to work in.
Well, let's just follow that thread about career, because again, a very inspiring career paths on this panel as well. Could you just, because you did say that you also felt like you had the calling to be a nurse or move into that field. Could you just describe your career?
Well, I was compelled to go into nursing for a number of reasons. One is I wanted to make a big impact. I wasn't sure exactly how to do that, but I thought this was a space that I could make a big impact. Now my impact is at a leadership level. At first it was caring for patients. I also have been intrigued by the science of nursing, the science of medicine and the human body. I think most of us are attracted to how things work. There is sort of an engineer in all of us nurses, I do believe. And had the opportunity to work in direct patient care for about 10 years in psychiatric nursing, but then realized that for me to make a bigger impact, I needed to shift gears a bit, move into administration, and now into nursing leadership, where I don't just touch one patient, but I touch millions of patients through the 7,000 nurses that work for United Health Group every day.
And Carl, you were in military, and that seems to be your path. Could you just tell us a little bit about your path?
Right, but my love for oncology nursing really started when I was probably 7 or 8 years old, and as I shared with you, I had an aunt, my father's sister, who died of a very unusual brain tumor, and she had 2 children I was sandwiched right between those 2 cousins, and so she died, and I saw what cancer did to that entire family, because my cousins basically their childhood was over and they were forced to become adults. So I always was fascinated with taking care of people, but somehow I wound up as a dental hygienist in the Army. And it was seeing patients with oral mucositis breakdown from chemotherapy that I was drawn back to cancer and my interest in symptoms, and decided that I'd like to go on to be a nurse, so I became a nurse. And I was fortunate to be in the Army for 20 years, where they paid for both my bachelor's degree, my master's degree. They let me work in, the Army's not really, their focus really isn't oncology care, it's trauma. But we do have patients and family members who do have cancer. So I was very successful for 20 years to be able to work and do just about everything. And then went on to get a PhD. And now, because I had such good mentors for me, to say, you need to go and get a master's, you need to go and be a PhD, you need to go to Capitol Hill. It's hoping that I'm being a mentor for those students, because I think that's really what keeps people in nursing, is having a mentor, but then being able to be a mentor for somebody else.
Thank you. So I'm getting flagged by Caroline that we have a lot of questions. So I'm going to pass over and let Caroline start to ask some questions, please.
We have excellent questions. A question from Dr. Sue Neville of the New York Institute of Technology. Dr. Neville asks about myth and reality. Here's a question for Pam. Isn't it a myth that we need to be generalists before we are specialists? Haven't we moved beyond that, and isn't education really a matter of critical thinking and case-based learning? Many new graduates go into specialty programs, but don't we need to match the exit competencies better with entrance expectations, workplace entrance expectations? It's a problem. Can you comment?
Sure. I do have a belief that in the way the work environment is changing, that a lot of nurses who want to go into specialty areas, they have to go through the medical surgical route first, and then they go into their institution and they will get quite a bit of training in whether it's pediatric or OB or psych. And I feel that nursing school is just the beginning. It's the just beginning competency level, and then it's the continuous learning after that that really supports students or nurses going into their specialty areas. I personally would like to see, with the technologies that's been mentioned here and simulations, whether it's virtual, whether it's in the lab itself, that we spend more time training in the virtual environment, in the lab environment, and reduce some of the time in the hospital environment, because we don't get the good experiences that come out of the hospital environment. Our students go into that area and it's a hit or miss, whether they really get to see a delivery or whether they really get to even touch a pediatric patient. In most cases they don't. But we could provide those kind of simulations and those kind of experience in the simulation environment and in the lab environment. And so I feel that nursing needs to take a bit of a turn. And with that, the state boards of nursing need to take a bit of a turn, because we do have to answer to the boards and to our accrediting bodies. And I think our environment is different than it was 40, 50 years ago, whenever the Nurse Practice Acts were open and whenever they set the regulations for nursing education. And so I think we have some challenges ahead. I think we have some opportunities ahead. But I think we can really meet those needs if we can just change a little bit of how we do education for nurses.
Thank you. A question for Carl, because you brought up the question or the issue of mentoring. This question is from Chris Calkins of Penn State University. Given the shortage of nursing faculty, should we consider all nurses to be teachers and teach them how to teach as part of their nursing education?
Yeah, I think that's a great idea. You know, I think that we all are teachers. We nurses that are working today in wards are teaching patients and are teaching each other. And it's really going to be an answer to the faculty shortages, is that we're going to have to reach out to those nurses that are working in units that may not necessarily see themselves in the role of faculty. I know when I went to the university, I thought that every faculty member had to be a PhD, but that's not necessarily the case, that there were great masters prepared and BSN prepared that were really helping to teach that same level of nurse. So I think it's a great idea to think of us all as teachers, and it may be a eventual pseudo-solution to the nursing shortage.
Excellent. A question from Irene W. Lee, who is co-chair of the Healthcare Careers Task Force for the Deaf and Hard of Hearing community. And her question, and perhaps this is a good question for Parvati, about to let us know how technology can support the goal of integrating more deaf and hard of hearing nurses into the workforce? Are there any technological solutions that would help employers onboard the deaf and hard of hearing underserved nursing population?
That's a difficult one. Certainly, when one does any technology development, there is a requirement that it be accessible. So for every piece of verbal media, we are supposed to provide text media. Every image has to have an explanation. So the infrastructure is there. Whether people use it today, that's still questionable. And it's something that can be done, maybe isn't being done. In our virtual environments, for example, where we emphasize verbal communication, actually we have a text chat capability as well. So you really could do both. But I have to say, I'm not sure that people are giving the emphasis that they should to supporting, for example, the deaf and hard of hearing.
Thank you. Another question for Pam. This is from Carol Johnson of Howard University. She says, I have a daughter who has a BS in economics. She wants to become a nurse, but she can't find any evening programs. Would more evening programs help with the shortage of nursing and helping learners access the courses they need to develop the skills for the workplace? How can more flexible scheduling increase the access to education for working nurses or nurses who want to change professions, in this case from economics into nursing?
There's a lot of people who are recareering, male, female, going back to school, and they are going into healthcare for the very first time. Many universities have what they call a recareering cycle for those students, and because they usually come in with a baccalaureate degree already, many of those credits will transfer over, all the general education sciences if they have those, and then they go directly into the nursing courses. Now those programs are great opportunities for adults who are recareering and have the economics degree but yet want to go into this environment. And many, like I said, many schools have that type of a program. I think that the next then issue has to do with flexibility, because most of the students are working, do have to have a mortgage to pay, they have children, they have work schedules, that the more that the universities, such as ourselves, the University of Phoenix, our students attend class in the evening. If they're on a ground campus, they're in class for 4 hours. They have 4 hours of additional study time that is required. And our courses are shorter in length, anywhere from 5 to 6 weeks. Our clinical courses are about 7, and our nurse practitioners are a little bit longer. But we have the student take one course at a time. They complete that one. So as a student, I'm just concentrating on this course before I go into the next course. And our surveys show that students really enjoy that type of classroom environment where they can concentrate on one course at a time and become competent to that and then move to the next. And then our online, of course, which we have a very large online component of our students, they love the online environment. First off, they are self-starters, they are independent type of learners, and they do not hesitate to speak up whenever they have a need, whether it's a computer need or instructional need. They raise their hand and faculty addresses their question. But oftentimes I hear the story, and students come up to me frequently and they'll say, you know, after I put the kids to bed, then I get online. I'm online for a couple hours. I chat with my faculty. I chat with my other students. And because students across the nation and sometimes internationally are all doing the same course, for example, family health. So what a rich environment it is to have students from across the nation talking online about their coursework and then what's happening in their community, what's happening with the families that they're addressing, and the teaching and learning that's occurring. So I do feel that today's learner is not only just technically more savvy than any of my instructors were, and certainly probably more than I am today, but they want diversity in how we deliver education, and that definitely is the future of where we need to go, because the world is not the same as it was a few years ago or 10 years ago, and people could go into an institution and complete their entire degree.
And time for one last question. This is for Dawn. Why do nurses need business and leadership skills, and how can employers foster nurse leadership?
It's also a really great question, and I think herein lies some of the tension in nursing right now. Is nurses possess great skills of caring and compassion and relationships, but the world is changing. And so we need nurses that not only possess those strong skills of intrinsically, why did I go into nursing? What makes me a great nurse? We also have nurses now who are serving in leadership roles and truly transforming healthcare. Two of our nurse practitioners more than 25 years ago created a very different model of care for the frail elderly called Evercare, which really was landmark in terms of changing policy and the way that we think about care delivery for this fragile population. So I would argue it's both. It's good clinical skills, good caring compassion, and good business acumen. And so I'm really promoting how to support nurses to make clinically relevant decisions in business environments, because to really materialize on the threads of the Future of Nursing report, where nurses practice to the full extent of their training and expertise, they need to have a different kind of skill set. They will serve as small businessmen and businesswomen, and that requires acumen in finance, systems thinking, communication, and other skills. So how do employers do that? We're doing so by partnering with a leading academic institution where we can draw on business school faculty, but ensuring that the nursing lens is brought to bear, that it's not just purely an MBA. But I think there are other resources available and other innovations such as we've initiated to really help close those gaps.
Well, I think we're out of time, but I'd like to thank our panelists for the second panel very much for your time and wisdom. And I hope that you'll stay around, because I think there's a lot of questions. I see the fan of questions over there we didn't get to. And thank you all for attending today. We appreciate your time. Thank you.
Hi, Chris Layton with the Chronicle again. Want to once again thank all the panelists, great panels 1 and 2. Thank Tracey for moderating. We also want to thank the University of Phoenix Research Institute for making the event possible today. And I'd also like to reintroduce and turn it back over to Dr. Bill Pepicello for some closing remarks. And then after that, we've got an opportunity for refreshments. And if you'd like to stick around, we've got some extra time. So thank you to the audience for attending as well. We really appreciate your engagement and taking the time to join us today.
Thanks, Chris. I'd also like to extend my thanks to all of our panelists who did a fabulous job today, and we certainly appreciate the breadth of expertise, the level of education that you brought to this discussion today. I hope that this is not the beginning of a conversation. I hope that what we've done today is bring to the surface conversations that are taking place all over the country right now. I'm struck by the breadth of representation of people as the questions were asked, that there was clearly interest that was not just local here, that these are national issues that are being discussed. And I think I would be remiss without a call to action here, which is one of the things that has happened today is we have certainly discussed the issues that are on the table right now, and we've discussed the solutions. And I think the people who are represented here today are perched on the edge of innovation that will take nursing and healthcare where we want to see it go. And so what I would urge people is to understand that knowing the issues, having talked about the solutions, it's the people in this room who can get us from here to there. And so I hope that you'll take advantage of the time at the reception here to make some connections. I saw people nodding and people saying during the break, we need to talk to each other. I hope that those conversations will take place, and that what will happen here today is not simply a great forum that came and went, but a forum that may, for many of us, mark a real milestone in moving things ahead. Again, thank you all for coming, and we certainly invite you to enjoy the reception here and continue with the conversations. Thank you very much.